Dr. Salem?
Hey, great to see you here, Dr. Amols. How's it going?
Good. I see Dr. Johnson's coming on here in a second, the Fibroid Slayer. So,
Absolutely. I'm so excited for this show. I've been excited for this one for a while, and there he is, the man of the
yep,
hour, the Fibroid Slayer. He needs no introduction, but I'd love for him to give an introduction as well.
If I can get
absolutely.
myself together here. My apologies. Yes. Sorry about that.
Hey, Bear, tell us a little about yourself.
So Dr. Pierre Johnson, aka the Fibroid Slayer, born and raised on the south side of Chicago. Just a passion for OBGYN since a young kid. Just growing up seeing all of the disparities in my community. And then, in medical school, just learning about how the origins of everything we know from an OBGYN standpoint came through slavery and off kind of like the backs of Black women in slavery. So just from that point, I just kind of went on a crusade to make things better and bring it back to my community. I was fortunate enough to actually not match into OBGYN coming out of residency, which was like the best thing that ever happened to me. I did a year of general surgery, which really cultivated everything for me. I was a barber, and I started off cutting hair in high school and just cutting hair, and then I actually worked in a barber shop. I was a barber for a year before medical school, and just really realized that I'm really, really good with my hands. So just the whole pathway of training. I didn't get into my OBGYN residency at first, general surgery, and then I went to a program that was just focused and just set for me to learn every surgical skill that I could possibly do. It was just so many opportunities to learn, and I took advantage of every single one of them. And just on my pathway, just build a surgical expertise until the point where I just took on every case coming out of residency. It didn't matter what it was, no matter how big it was, just crazy stuff that people 20 years into the field would never do. I never said no to any case. And it allowed me to be able to build a skill set and a confidence level that I bring today into where, women from all over the country, all over the world now I'm international. I have international patients come in for fibroid surgery and able to not only preserve a uterus, but to do it through very small and minimally invasive incisions that I'm very, very proud of. So to date, I've never done an open hysterectomy. Everything has been either robotic hysterectomy, myomectomy, as I do open with the very small incisions, and I'll talk about that, of why I do that. But biggest robotic hysterectomy is 15 pounds. Largest myomectomy was over 20 pounds. So I got a lot of things I'm proud of, but I bring these skills to forward, not to be braggadocious about it, but to show women that things can be done, and that they have options, and that no one should rob them of their fertility. If they really truly want to be moms, then there's people out here to help them. So that's me.
It's interesting that I don't think people always understand how difficult, those surgeries are. Like, I've had surgeons who will try to remove fibroids and then they leave still 6 or 7 of them. I saw one of your cases where, every single fibroid was gone. And I did a podcast actually last night about this and was talking about how, to be able to do this non-invasively the way you do it takes a lot of skill. I can do these open, and doing them open is a lot easier, but doing this through laparoscopic with robotic is pretty impressive. And I was looking at a lot of your stuff, and I think the thing that I love about what you do is there's a lot of people who are told just have a hysterectomy, and just not be able to go through a myomectomy like you do. And so, like I said, it is really impressive, and I hope our patients and people who see this tonight realize what it means to have a skilled surgeon versus just having someone who's just a generalist. I think that general surgery background, I can't imagine the skill set that must have gave you. So
it was priceless, man. I was literally, as an intern with plastic surgeons, me 101 for 2-3 months at a time, and it was I was at Washington Hospital Center in Washington, D.C., and it was just a plethora of just opportunity. And so by the end of that first year, I went to OBGYN, like pretty much the skill set of like a third or fourth year, resident as an intern coming in OBGYN. So when I came in, attending, I went to a program that it was like in a community where there were a whole bunch of town docs and only a few residents. And like, so you could just pick and choose whatever case you want, just, as an intern being with laparoscopic hysterectomies, open hysterectomies as an intern, I took full advantage. My second year, I was able to train and get on the Da Vinci. I literally did all of those modules in about 3 weeks, was staying in there till about 3-4 o'clock in the morning every day, just so I could hurry up and finish. And then by the time they let me go, they were like, well, damn, what else? Let him go. And, so like fourth year, I was literally doing sacrocolpopexies and, these complex surgeries unassisted. And attendings would just like sit back and just watch me. And I took advantage of it. It was great, man.
That's awesome. Seems like it was a pretty good deal for them too. They could just chill out and have you do all the hard work.
Yeah. Heavy lifting. Just say they were there, write their name on it. I have to do the op note and everything. I wish I could have something like that now. It'd be great.
Well, I imagine that's going to be, the future not too far away. You got to train another generation of fibroid slayers. But I have a lot of things we'd love to talk about today. We'd love to encourage people to come onto the show, ask questions for Dr. P, and one of the biggest ones that comes to my mind, because we have a lot of women that come in. Of course, their main priority generally when they see us is fertility. And I'm sure you have a lot of these same exact patients. They come to you and, they've probably been recommended by other people before they've had the pleasure to see you that, hey, just get the uterus taken out. You have a huge fibroid. You're talking about fibroids that most people wouldn't touch. They just say, you got to have a hysterectomy and then you could never get pregnant again. Take me through that a little bit. How do you talk to women that you take care of about, hey, you do have a really big fibroid here. And when do you consider doing a myomectomy versus when do you say, boy, this is too hard. We gotta do a hysterectomy. I mean, in your experience.
So for me, I personally feel that no fibroid is too big. It just isn't. And to be honest with you, and people would be shocked at this, the bigger the fibroid, the less the damage to the uterus is. Mm-hmm. If you look at some of these like ridiculously large fibroids, oftentimes they're pedunculated. Yeah. They're really not damaging the uterus, to be honest with you. So we have a big fear about them, and it's really not as bad. It's more so the smaller ones, and when women have really advanced disease where they have 70, 80, 90 fibroids that are in there that are riddling the uterus, where it becomes more of a problem. But some of the bigger ones are really surprisingly are not as bad. There's some more of my easier cases, and for me, I stand true to that. To date, I have the only 2 patients that I've had to unfortunately perform hysterectomies on when doing a myomectomies were 2 women with cancer that had leiomyosarcomas. Yeah. Other than that, I have been able to successfully, knock on wood, but successfully do a myomectomy in every single patient that I've operated on. And it's been some tough ones. I don't want anybody to get confused. It's been very tough. I've been on the fence with several of them. To thought one woman went to DIC. You can't control that. If you're bleeding, you're on the fence there. I've had some very, very damaged uteri to where I actually had to call out to the family and say, listen, this is a lot of damage. Is this what we want? Talking to her husband. And they reassure me that yes, this is what she wants. And I do it, it's because to me, it's not our job to play God. It's not our job to say someone can or cannot and use our opinion in it. For me, I never tell a woman, oh, it's impossible for you to get pregnant, or this is something that you cannot do. Speaking indefinites to women is not only heartbreaking, but it's inappropriate, I think. So my conversation to them, you know, and I'll kind of walk you through, walk everybody through. I have a very, very pertinent question with every consultation I have. I said, what is your major goal? What is your goal? And a lot of them will say, hey, you know, I just want my fibroids gone. And I stop them there. I say, that's not a goal. That's a desire, right? I need to know what your goal is. And if you have advanced fibroid disease, you only have two goals. One goal is you want to be a mom. You will do anything. You'll run through a brick wall. You'll pay however much money it takes to be a mom. The other goal is you want to fix your symptoms. You want to be normal as it pertains to people not calling you and saying you look like you're pregnant or going through bleeding and pain. And that's the most important thing. When it comes to that, I'm the most important person that they have. But as it pertains to you wanting to be a mom, my ego is aside. I'm not the most important part of that equation. I'm second, third in that, you know, because the most important part of that is you guys, right? You know, because I can do a myomectomy all day long and you have a pretty uterus and everything, but if you don't have the egg quality, if you don't have the eggs to be able to put people in your house, that's a problem. So we start fertility consultation first if you want to be a mom. And I'm very honest with them about that. And yeah, that, you know, you guys can tell them, hey, we can't even get to your ovaries because your fibroids are so big. Then we talk about surgery. And then right after, then you go get eggs still. But eggs is the primary thing that we need to focus on if the goal is becoming a mom.
Impressive. I mean, I find a lot of people who remove fibroids don't talk to them. I get patients sent to me all the time who are 45 years of age. They come to me and the doctor's like, okay, I got their fibroids out. They're ready to have a kid now. And exactly what you said, I think, wow, if they would have known there was almost no chance of getting pregnant because they have basically, you know, near menopause, but they may have not done that surgery. They may have just said, you know what, I'd rather do the hysterectomy instead now or something like that. And so I think that's quite impressive if you do that, because I don't find that a lot of surgeons always do that. And, you know, evaluating sometimes even, I would even bring a point that for some women, it might even make sense to even, like, if they can, have their eggs, you know, taken out ahead of time or something like that. I have a question for you, and I've never had to deal with this. I removed some big fibroids too. Again, all mine are open. I'm not as talented as you surgically. But I have heard of, you know, people sometimes, like, they do lose their uterus. Like at some point it just is too much, or, you know, it's not going to be able to be used. And I mean, that conversation, I mean, that's got to be a hard conversation, because especially if that was their goal, if that happened. I mean, and again, I'm sure it's a very rare occurrence or something like that. But I mean, do you talk to them about then, like, the idea of gestational care, have them, you know, see a fertility specialist too? I know it's not common. I mean, it's extremely rare.
Yeah, it's I'll talk to them. You know, that's a risk of surgery that I always talk about. Like, hey, you know, there's a risk of infection, bleeding, injury to things, and there's always a risk of hysterectomy. I'll never risk your life for your uterus. If it's your uterus versus your life life is going to win 1,000 times out of 1,000.
Yeah.
You know, so I'm very honest with them about that. You know, but to then I go extra hard when I have someone that's really serious about it, and when they have went through all of the steps and have tried to do everything that, you know, hey, I've been the fertility doctor. I've done the things that you've asked me to do. So now it's on me to go back there and give them my all. And, you know, like I said, it would be definitely a hard conversation. Like, for instance, the patient that had cancer, like, it was a very hard conversation, but, you know, she understood. You know, that's a life-changing thing. I mean, it's a life-threatening thing if you have a life-threatening thing. But like I said, I've done some really amazing things, man, with some damaged uteri. Like, I literally, like I told you guys when we talked before, I'm going to show you, but I did literally, like, endometrial implant, like, where I literally pulled this woman's large dominant fibroid out, and about 70% of her cavity was attached to the fibroid.
Now hold
And
up, hold up, hold up. Before you give away the punchline, take us
yeah,
back because we got some viewers that you're doing a deep dive now. This is like a deep cut into the world of endometrium
yeah,
and all that. So
call me too.
take us through what the problem is, right? Like you're talking about fibroid distorting the uterus. So just take us through your thinking about how a fibroid can kind of negatively impact, harm the uterus, and then take us through what you're about to tell us, because this is really interesting. This is super novel. This is groundbreaking kind of stuff. So I want to, yeah.
So, for all the viewers, it's fibroids, are problematic, like I say, for two different reasons: size and location. Um, Size, typically, if fibroids are so big where they're pressing on different parts of the body, organs, they can be problematic. But more importantly, location. So the way I explain it, is to my patients is like you look at it like a house, right? So house, you got your brick and your chimney. Then you have the drywall, and then it's the part where we're actually talking in. It's the actual room where you're at. The room where we're at is where people are at. So if a tree falls on your house and it falls on the roof, no harm, no foul. Really, you won't know what's happening. You're in your house doing well. But if that tree falls through not only the roof, the drywall, and now comes to where you're at, now you have raining inside of here. That's a problem. And so those are the ones that are very problematic. And when you do that, the house and where you're at is extremely important, right? That's the entire focus of your menstrual cycles, where your babies come from. Like, that is sacred. And so if fibroids are putting damage to that, removing them, once you remove them, it is paramount that you meticulously repair the inside of the house, like the inside of that room. And to that point, and I tell women all the time, like, when I get in there, I have no idea what I'm going to find. Right. And a lot of times, and people are like, well, why don't you get another MRI? Why don't you get another? It's not going to change anything for me, because I actually would like to come at this where my mind is just open to create and to think outside of the box. Because if I go in there one way and then I'm thinking something and then something's totally different, now I'm a little jaded with my thought process. So I like to go in and start to create. And a lot of times, if you have branches that are falling into your house and that or to that room that are causing problems, not only do I have to remove that branch out, now we have to repair the inside of that, and so that it is like nothing ever happened, like it's flawless in there. And that takes a very high level of meticulousness to do that. And that's why a lot of doctors will leave fibroids back, because they're so scared of doing anything to the cavity. And if any fibroid is there, and I'm just like, well, if you leave that because you're scared of it, her chances of pregnancy are minimized anyway. So you have a much better chance of removing and then paying close attention to putting things back together than to just leave it. So you have no choice, in my opinion, but to remove every single fibroid. One, to structurally put things intact so that you can optimize her ability for pregnancy. But also, too, to date, I have not had any repeat myomectomies. And the reason why is because I look at it just like a law of averages, if you will. If I remove every single fibroid, then it's not to say that you won't have any fibroids that ever come back. It's to say that you don't have enough time in your ovarian life to now grow a new one, and then for that new one to grow big enough to become a problem. Because if you're 46, 47, somebody does an ultrasound and they get a 2 or 3 centimeter fibroid, I don't care. You shouldn't care. I care if you come, that same age and you got a 12, 15, 20 centimeter fibroid that I have to operate on again. So I set that stage very clearly. Now, moving on to, some of my cases as far as like the damage to the endometrium. And this is why my approach to myomectomies is the way it is, and it's different. Number one, you have to be so very meticulous. And so into the case that I was talking about, like literally, just imagine instead of that tree branch falling and into the room, the entire tree falls into the room, and it rolls and it rains in there for months and months. That's the equivalent of what this woman had, So when I went in there, and this large fibroid just embedded inside of her uterus, I have to shell it out, and I'm shelling it out and shelling it out, and it appears to be just fibroid. But by the time I get it out, what's remaining in her uterus is pretty much all myometrium or drywall or the muscle of the uterus. And I'm looking at the fibroid, and it has this opaque structure on it, which is the endometrium. And so, and honestly, at that point, I had never seen it. But I just had to call out to her husband and say, hey, this is grave. This is something that I haven't seen before. And I think that it's really, just a difficult situation. And I remember, I go back to her conversation before she came to me. She trusted me to do something for her. And then when I asked him, he, as a husband, he didn't want to make the decision to remove her uterus. So he just said, hey, please just do everything that you possibly can. So at that point, I had to do what was right for her. So meticulously, I had medical students and residents in there. And I said, this is what we're going to do. Everybody is going to, and I got extra medicine balm scissors in there. And I said, let me show you what I want you to do. I want you to stay really, really close to the fibroid, and I want you to slowly start to peel this layer off, because it's the layer that we need. And I just started to peel, and I had about 2 or 3 large pieces of it. And then there was also still probably about maybe 30-40% of the endometrium left, and I could track it up to the tubes. And I just kind of, from there, I just literally started to piece it like flaps, if you will, together to recreate her endometrium like a puzzle piece, and to where it fed the tubes. And I put meticulously sutured the layers of the endometrium, not to oversew and not to make sure that they're not impinging on each other, but so that they're reapproximated.
I think little technical difficulty there. I think we just lost the image and the
yeah. So what he's talking about, he'll be back here in a second, hopefully. Let me see if we can get him here. If everyone's trying to understand that, so there's a portion inside the uterus, which he's talking about, the room. That's where you can't get hurt. That's the endometrium. And then outside of that, you have, like you talked about, the drywall, and he talked about, it's a great analogy actually. And then the muscle. And so he's talking about that. Imagine if someone took just the room out and it was stuck now to the building side, and then he somehow put the room back in, which is insane. I mean, it's not simple. You have to use very small stitches. You have to be very careful. You have to be very good with your hands to be able to do something like that. Yeah. A lot of times people just ruin the endometrium, and so it's actually quite an interesting story. When he comes back, I'd love to know, well, again, I'd love him to finish the story, because I don't want to ruin it forever for him, so I'm going to let him finish it. But a question for you, Dr. Salem, while we're talking about fertility and fibroids, there's a lot of kind of controversy about fibroids, right? We all know that when fibroids are in the cavity, there's an issue. But the question is, I'm going to let you keep going. We were just talking about some. I'm going to let you keep going. We were just kind of explaining to them what you were talking about, how interesting that was. You still there?
Yeah, I'm here. Can you hear
me? We were just explaining to the audience what you were talking about, giving a little bit more detail. Your analogy was fantastic, but I'll let you finish, and then we were going to talk about some of the controversies with those.
Got you. Yeah, I'll finish that really quick, because I was getting kind of an attention. But yeah, so I put it back together, and I said, if God's will be done, if this is I could look myself in the mirror at the end of the day and say, hey, I did everything I possibly could for this woman. I did the right thing. I didn't make a judgment to say, hey, she's not going to get pregnant or what have you. I did the best that I could do. And any patient or any person will respect and appreciate if you do everything that you possibly can do. And you can honestly look yourself in the mirror and say, hey, I did everything I could do. And lo and behold, she definitely has really regular monthly menstrual cycles.
That's amazing.
And I would be shocked to say her pathway to the tubes is intact. It may or may not be, but nonetheless, if you do a hysteroscopy, put a camera in there, and it's pretty clear. There's really no reason why you couldn't put an embryo in there. If it's intact, so she has a chance. And that's the thing. It's just giving people hope and chances that really want to do it. I don't necessarily believe in not having a plan, doing a big surgery like that for people that really just don't have true plans to get pregnant. I don't believe in doing it for women that just say, hey, I just want to preserve my uterus. I just want my uterus, or what have you. If you have advanced fibroid disease and you need surgery, saving your uterus should be accompanied with a benefit. And that benefit is the opportunity, at least the opportunity for you to be able to get pregnant in the future. So that's that.
Have you, do you ever stained inside of the endometrium before your surgeries?
You said stained it?
Yeah, like with like indigo or something, just to kind of make it easier to see when you're doing the surgery.
I have not. I think that's an awesome idea to do, but I have not. I've seen so much that I can really I can find it. I meticulously find it. And one thing that I do that's not popular, but I actually go to the endometrium, like in every case, just because I want to assess the cavity. I'll make a small incision there just to see and make sure that the cavity is intact, especially if it's very close to it, and just meticulously repaired, because I don't, a lot of times, we do these extensive myomectomy cases, and they'll have submucosal, fibroids and things that are just left because you just don't know it's in there. So I like to be very, very thorough to make sure things are not. And, proud to say I have so many women that have gotten pregnant. I just got off the phone with a very close friend of mine, childhood friend of mine. His wife is now 33 weeks pregnant. Now did her myomectomy maybe 3 years ago or so. So, it's a lot of success rate.
Awesome.
So doing the right thing.
Do you enter the lower uterine segment, or do you go near the fundus when you go? Because you said you always go into the cavity.
Yeah, I try to go into the body, just make a very small. So usually I don't have to do that. Most of the patients that come to me have cavity involvement anyway, so I don't have to do that. Yeah. But I try not to go low. I try to go into the body, if you will, and just make a small incision just to make sure there are no fibroids or anything, and that their cavity is clear. I can assess the pathway to the tubes, and just document that, video it, and show like you guys to say, hey, this is what she has. This is everything. And you don't read my op notes, you look at video to see what you're working with.
That's great. I know we have some questions coming in here that people really want to get you to weigh in on them. So where do you want to take it, Dr. Amols? I see a few of them.
Yeah. Well, before when you were off for a second there, I was bringing up the idea of like what fibroids really affect fertility. And I think there's some controversy on this, because the thing I was starting with is Dr. Salem. We all know the ones in the cavity affected. That's proven. No one questions it. There can be inflammation from the fibroid. I mean, I'm sure you pulled out, submucosal fibroids that just look like, they're inflamed and stuff like that. The question comes is those ones that are abutting the cavity, the ones that are right next to, or just about going in, or even these ones that just distort the uterus a little bit, even though they're not in the cavity. Like I always tell people, here's the cavity, and I put this giant thing there. It's like, well, it's technically not in the cavity, but it's really distorting everything. What do you talk to patients about that? Because I know, one of the things I have to tell people is, listen, we don't know. I mean, but there's no question they do sometimes affect it. I've had patients where I've done transfers on, beautiful looking internal uterus. I put a camera in there, looks great. But I see this humongous fibroid there,
Right there.
fails and fails and fails. Then I say, you know what? I don't know what to do. You got to get this removed. Gets it removed, and crazy enough, it works, and they have a baby. And so I wasn't sure if you get that question a lot, and that's one of our questions that are kind of here too as well.
Yeah, to that point, yeah, we don't know a lot, but just thinking about the physiology behind it, you know, radial arteries are there, you know, so that fibroid, well, fibroids definitely they do a phenomenal job of commandeering blood supply to anything that's close to it, and it's very difficult to believe that if it is that close to the cavity to where it's impinging upon it, that it does not share some of that blood supply, and that it's compromising the blood supply to the endometrium in that area, which for a early implantation of a placenta, or even the growth of a placenta, that's detrimental. You know, so to that point, I tell them, like, you know, we don't know exactly what it does, but we do know for certain that women with fibroids get pregnant at a lower clip than women without them. Right. So if you are at the point where you are at the end of the road, for lack of a better term, you know, you're early 40s, late 30s, and you're going to spend a lot of money to achieve your dreams of pregnancy, you want to give yourself the very best opportunity. You don't want to have anything left to chance. You don't want to have 1, 2, 3 miscarriages after that and say, well, damn, maybe it's possibly the fibroid. You want to give yourself that best opportunity to do that. And so that's why I tell them, you know, when I go in there, I'm removing them all. And if you're having issues with pregnancy, and we have fibroids that are close to the cavity, that it's in your best interest to remove them if you are in that position where you need this to happen sooner rather than later.
Yeah, absolutely. Dr. Salem, we got some questions here. So Dr. Salem, I'll let you start some of these off here.
Yes, absolutely. I mean, I see a lot of questions flowing in here, and a lot of people have some excellent questions. And one of them is about hormone imbalances and the risk of developing fibroids, and kind of what your experience is with that, Dr. P. And, you know, we're happy to give our, 2 cents on this as well. But, what's, talk a little bit about who's predisposed. I mean, a little bit of this question is talking about who's predisposed to having,
Exactly.
Fibroids. And I think we can kind of talk about some other things that you were mentioning earlier as well. And so, yeah, why don't you just take it away there?
Sure. So the most promising study that I've seen, is a study out of University of Chicago, where they found actual genes that code for fibroids. And for these women that have these genes, it's almost similar to, a BRCA or Lynch syndrome or any of the other oncogenic genes that we know about, that they have a very, very high propensity for growing fibroids. And they are doing research as far as preventative measures to prevent some of these fibroids with vitamin D and some of the other things that they found that have shown some promise. But the thing that they have not figured out is why certain women will have a 2-centimeter fibroid for 20 years versus a woman that will have a 2-centimeter fibroid 1 year, and then 3 years later it's a 15-centimeter fibroid. That information is the biggest mystery, and that's what I talk to my patients all the time. And so, in my personal experience, what I experience is that African American women do have fibroids at a higher clip, but more importantly, they are the ones with advanced fibroid disease more so than any other culture or race. And there are a couple of reasons that I think that are not well studied or paid attention to as to why that is. Number one, I definitely think from a cultural standpoint, just the lack of the access to quality foods that plays a part in it from a socioeconomic standpoint. But even more importantly, just, not to get too deep into other issues, but our country, is that, there's a common stress among culturally, stress is a factor that plays into fibroid growth that we don't account for. And then from a cultural standpoint, a lot of culturally, these women are now starting families later, or now putting school and putting a lot of other different things first, and then having children at later times, whereas culturally it's not as much in other cultures where women have children at an earlier age. So I think it's a culmination of those things. As far as the hormonal imbalance piece to it, I think that there's some truth to it, but I don't necessarily think that that's the key or the answer to it all. I think it's bigger than that. It's not many disorders that have just huge hormonal imbalances to where you have floods of estrogen that could be accountable for some of these growths. PCOS is one, but many women don't have PCOS and have large fibroids. And I tell women all the time, listen, I operate on vegans, vegetarians, and some of the healthiest women on the planet. So just to say that a particular food or a particular one thing does it is, I think, negligent. There are multitudes of different, it's just multifactorial as to how it plays into the growth of these things happen. But I think that, like I said, University of Chicago has really, really found some very, very promising information that we can utilize moving forward as far as preventative measures to counteract the growth of fibroids in women that are highest risk, that they're working on now, actually, which I thought is extremely interesting. They're trying to create testing similar to a pap smear, where you can test to see which women have these fibroid genes, and now do some of the measures that they found, such like vitamin D replacement, as well as some of the other herbs that they found that have helped in preventative measures of growth. So I think that's very, very promising. But I know everybody wants answers. There's still a lot of unknowns, unfortunately. The good thing, or the positive thing that I think people should understand, is that the overwhelming majority of these cases are benign, meaning women are living through it, because it could be much worse. This could be 10-20%, cancerous and deadly, but it's not. And to that point, until we figure out the preventative measures, we can find ways to treat and different options to make this workable for everyone.
Yeah.
I used to work with Epi Stewart at Mayo, and she actually did a lot of this research too. She was actually looking at generational in African American women, and how the grandmas would have it, and they were trying to find this gene. It was actually some of the work that led to that. It's really a big portion of her work. It really does overwhelmingly affect African American women more than any group. There's no question about that. It's interesting. Anecdotally, I've noticed a lot of Indian patients having fibroids as well once they come to, especially in the United States. I don't know, it comes back to that diet or something, if there's something different, because obviously it's a huge cultural change in diet coming here. But that's really cool. We actually have a guest on here that, so we're bringing her to this, or her to the stage, and probably has a question for you. Their mic is muted. I don't know if the guest knows their mic is muted. I'll wait for them to come on. I had a question for you. One of the things when you were doing surgeries that I wasn't doing in the past. So back in the past, when I used to do surgeries, there was a point that fibroid got too big that it was almost impossible to do surgery on, or the surgery became more complicated. Like, for example, I have to make a small incision in the back of the vagina just to pull out the fibroid or something like that. And now, obviously, with the morcellation and things you can do, you can get away with stuff. But if a patient found they had a fibroid, let's say they didn't know it, is there a point where they should maybe get it removed earlier than later to, be able to preserve the uterus more? Is there a point where you would say, you know, if you're getting to 6 centimeters, let's get this thing out, because if it gets to 15 here and it's growing fast, I'm going to have to do more surgery, you know, more concerns.
I take it on a case by case basis. I don't necessarily do it from a size perspective, or say, hey, it's reached a 7 centimeter or 8 centimeter, and you should operate. One, I take into consideration what the symptoms are, and seeing if it's really impacting them symptomatically. And then I also look into see what is the plan for fertility. Younger patients, I'm much more liberal as far as how to really attack things and how to give them options, because to you guys' point that an AMH of someone that has an 8 or 9, and has a little bit more time to work with, a procedure like an accessa or a laparoscopic radiofrequency ablation of the fibroid, just temporize growth and to help with symptoms, is much more of a realistic option than someone that's 43 that has been infertile for years and really is, has an AMH of 0.8 and needs to get eggs, and now trying to really move forward with an IVF cycle. Me telling her something conservative like radio frequency ablation is not the same, even though they both have 7 or 8 centimeter fibroids. And so it's never a size. I think it's more so an individual goal, and from an individual goal standpoint, as well as symptom standpoint, and a plan of like where you're at with your fertility desires, and that will then kind of lay the framework of what makes sense. Because I've seen, to be honest with you, I've had patients that had 9-10 centimeter fibroids, multiple of them, get pregnant, have full-term pregnancies, deliver vaginally, and do well. And so for me to tell her, hey, you should have had a myomectomy before, when she's doing perfectly fine without my help, it might be a mistake. She's probably going to need surgery later on, but hell, let her have her babies. And then if we have to deal with myomectomies or even hysterectomy when she's ready, do it at that point. So like I said, just from a case by case standpoint, I'm very careful to do like blanket statements to patients and say, hey, this is the way I do it, or what have you. I listen to them, I hear them, and then I kind of break it down and allow them to make a informed decision about what makes sense for them.
I think that's such a great point that you bring up, especially fibroids. It's not a binary thing. They can be in different parts of the uterus, different sizes, affect things differently. We talked a little bit about the inflammation response that they get, the pain symptoms that some women have. So I think this is such a key part of our talk today, is just like this idea of, you really got to hear out each individual, their story, what their goals are, not their desires, their goals, like you were saying.
Right.
And figure out how to get to those goals, appropriately, because it really can, change. I mean, we have guidelines, but that's only part of the story.
Absolutely.
Yeah.
Yeah, absolutely. Yeah. And I think that's a big problem that we have in medicine, not just in our disciplines, but across the board, is that there's a lack of listening to people. And a lot of women that come to me say that, hey, they pushed hysterectomy. They just said, I needed a hysterectomy, what that was the option, or what have you. And nobody heard you say, I really want to be a mom. And let's figure out how to get you there, and to say, hey, yes, hysterectomy is on the table, and it might be an option or even a better option for you, and surrogacy may be it, but hearing you out, giving you the pros and cons of everything, and then allowing you to ask questions about each thing, and then make an informed decision that makes sense for you without my bias, without my dictatorship, if you will. And that's a lot of times patients feel that they're being dictated to, giving them the freedom to make their own decisions. I think that's where the trust goes out, and where you have to empower people to feel like they are making the decision that makes sense for them.
Absolutely. It's interesting. I see a lot of people, who know you and know us, and even some of our own patients have had surgery from you. One of them, Amy here, was, saying it's same thing. We told her this fibroid's probably not affecting fertility. It's not the traditional one that's affected. And she actually ended up seeing you and said that she had surgery and it was very, the surgery was very successful. She said it was about 550 grams. That was the fibroid you removed. And, she was asking, could it potentially affected her fertility? And as I said, I mean, traditionally, no, we don't believe those fibroids do. But I mean, I feel like there's a lot of things we keep learning, and there's new things we learn about it. One interesting thing, and someone brought this up about fibroids right here, is that her fibroids grew after starting IVF medications, and what can counteract the growth due to medications. And she said, by the way, I had a myomectomy less than 10 years ago. And it's true. I mean, this is actually one of the things I talked about in my podcast, was that it's not uncommon for, when you're pumping someone with hormones and, if you have high estrogen levels, it's going to cause those fibroids to grow. And you made a really good point about the type, like, do they have that gene for the ones that are going to grow faster? Do they ones not? Because I've had some people, fibroid doesn't grow at all. 3 IVF cycles, not a single growth. And I've seen other from the beginning we start till 6 months later, and it's almost like double on the side. I mean, grows really fast. And obviously not like a sarcoma type of growth, but, grows faster than you would expect. Do you tell patients anything about, like ways to, you said, reduce estrogen, phytoestrogen, stuff like that, to stop the fibroids from growing, or just kind of say, no, I'm going to take it out and then you can just do whatever you want?
Yeah, I don't, because, one, I'll tell them, expect fibroid growth in pregnancy. It's typically going to happen. Whatever medications that you get, or even during pregnancy, most of the time it's going to regress back to its pre-pregnancy or pre-medication size after the fact. So don't get caught up so much in the growth while you are at a hyper estrogenic state, and don't get focused on that as much. Focus on whatever it is you're going through, whether it be pregnancy, whether it be going through a cycle, and then, evaluate later. Don't get hung up on it. But, to that point, I just, I people will ask all the time, well, why in the world do you not put some of these patients with larger fibroids on some form of suppressant first to shrink it? Why don't you put them on Lupron? Or why don't you, you got to make it smaller to deal with it? And I tell them all the time, well, if you do fibroid surgery extensively like I do, you would know that it is a nightmare to deal with someone that's been on Lupron for months and months and months, to deal with mushy fibroids and trying to get them out of there. It really sucks. So I want it to be hard. I want it to be in its natural state. That makes it easier to delineate between tissue planes. So it's be careful, to everybody listen, when you talk to your doctor about their plan to attack your fibroids and to preserve your fertility, like, make sure you know what they're talking about. Make sure that everything that they tell you makes sense to you, and it sounds good, and they're very sure about what they're talking about. It's extremely important. I hear some of the craziest things. I had a woman today. It's crazy. I'm recency that she told me she had fibroids, and she told me her doctor told her, well, for one, they diagnosed her with endometriosis, and they told her the reason why her pain is better, because she had horrible pain years ago and now it's better, but the reason why is that now her endometriosis has risen, and that she's bleeding more on the inside instead of on her uterus, and this is why it's not as bad. I said, what are we talking about? Like, it's like, I just said, so many times I'm talking to these patients, I'm like, what are we talking? Where did you go? but to that point, the shock and dismay that I have is just like, just imagine what the patient is feeling. You know, so to that, I just try to, and just like you guys, just try to arm women with the information, the knowledge, you know, when they can have intelligent conversations with their doctors as opposed to just listening and hearing whatever. It's really empowering, and that's how we optimize medicine.
One of the questions that came up, and this is a great one for you, is you know, it says they're in need of a surgery for a large subserosal fibroid. They're also going through IVF retrievals and trying to balance when they get the surgery and to ensure not to have another fibroid grow before getting pregnant. So in other words, kind of that thing I was saying about, you know, will the hormones make it get bigger? They're wondering, should they have that surgery first, then get the retrieval, or do the retrieval first, then get the surgery?
Yeah. So to that point, I tell every woman that I talk to, see you guys first. And if you do an ultrasound and you can access the ovaries, do that first, right? Because the process, and this is the same analogy I give them, no matter what, from the time they started to have their menstrual cycles to the time that we're having the conversation, the quality is doing this. And for every single woman, at a certain point, it's going to do this, right? And the misconception that we have is that it's always associated with age. At 35, it's here. At 30, at 40, it's here. At 42, it's here. Your aunt had a baby at 44 and you can do it. Janet Jackson had a baby at 50 and you can do it. And it's not like Janet Jackson paid a lot of money for that baby. You don't understand how much money she paid for that kid. So
Very lot.
Yeah, it's a lot. And so to that point, it's if you have the opportunity to be able to bank that early, the earliest you can do it, you're playing with house money. It's like being at a casino and you are, you know, at the blackjack table and you're winning. You just got stacks of chips and stacks of chips, what have you. Go cash those chips in as soon as you possibly can. Because if you continue to play, the casino's going to get their money back. And that's what your eggs are going to do. So if you can get that early, absolutely. Now, if they see you and you say fibroids are just blocking the pathway to these ovaries, like we can't get to them, it's impossible, it's like whatever, now you got to come see me. Now you got to come see me so that I can get the fibroids out the way and then access the ovaries. And to that point, we're not waiting 6 months or whatever. I tell my patients, give it a month. After a month, if they can push you through a cycle and go get eggs, go do it. And then we talk about implantation and all that stuff later. But, you know, as soon as possible to get it, you know, and see fertility specialists first if they can get it before surgery. If not, a month or shortly thereafter, get your eggs and get them retrieved.
I appreciate you saying that, because that is something I agree 100% on. I know some surgeons will want to go to the surgery first, but you're right. I mean, if you can get to them, might as well. Because again, surgeries can have complications. It might take longer until they can go back through. One of the things that came up, it was kind of interesting when you're talking about Lupron, which obviously Lupron's a horrible, you know, drug to be on. One of the patients was asking us, you know, if they're doing their egg retrieval will impact their fibroid. And as you said, yeah, it may cause it to shrink a little bit. It might cause it to, you know, soften. But in our process, when this person was asking this, because we're giving hormones, estrogen levels stay up. So they really don't have that, you know, that kind of shrinkage. And the other thing I was going to mention about the Lupron was I do a lot of hysteroscopic myomectomies. That's the one thing I got very good at. And I could do huge ones. I mean, it could be 4, 5, 6 centimeters. I could do in one surgery. And a lot of people would say to me all the time, why don't you give them Lupron? Give them Lupron. You know, it makes it smaller. And I would tell them, because I don't need to. I can do the whole thing in one case. You know, I mean, I was able to do it really fast.
What's your? Let me ask you a question about that.
Yeah.
That's a good question. What's your process, or how do you minimize your fluid deficit?
That's a great question.
Because that's the problematic cases that I've had when they're really big, and you could use the big MyoSure and really chomp away. But some of them, if you got calcified fibroids or whatever, you know, you chomping and it's just not going anywhere. And you look at your fluid deficit, now you're, you know, 1,500, 2 liters or whatever. What do you do to minimize your fluid deficit?
Yeah, so a couple things. I mean, one, the biggest thing, it obviously depends on the fibroid you have, right? So if you're calling pedunculated, I mean, a lot of times, right in the very beginning, I'll just chop it off and I'll just chew it up in there. I don't have to worry about vessels, But normally what I do is I try to stay away from the bottom as much as I can, because it seems to be where a lot of the big vessels are. And I usually start, a little more distal and work my way. But the thing is fast. I mean, that's the thing, is just going fast. I keep my pressure down a little bit lower, and I just get strong bites and go through. I didn't even like the Mousure. I used to use, back in the day, the True Clear, which was, I think eventually, they changed their name at some point. But I used to use that one. I thought that was a better system. Yeah. But you're right. I mean, it's just speed. I mean, that was really the thing, and I was able to, even when it got cloudy, because, that's the hardest part, right? As you start getting some bleeding, you can't see. I would just get close and still keep going. And, I just kind of planned it out right before I was getting in there. I'm not saying I've never had a case that I had to do a second look, but I don't think there was ever a case I didn't at least get 80% before I had to go in the second time. I mean, like I said, most of them I get it. And you can go, obviously we're not taking our boards right in here, so we don't say 1,500. But if we're taking our boards, we're saying 1,500. But you can go a little bit over if I'm close. Yeah, yeah. And I'm doing some late stuff afterwards. But it just depends where I'm at, right? If I got 60% more to go and I'm already having a huge fluid deficit, I'll go, okay, I'm gonna have to do this again anyways. Let's get the 50 and stop. But sometimes, I'm like 20% more. I look and I go, I can get this, and I finish it off. But you're right. It's a decision you have to make intraoperatively. Yeah.
I'd love.
Let me ask you this. Now I'm putting you on the interview. So,
I'm okay.
What do you feel about? Because this is I struggle with this too, as far as hysteroscopic myomectomy. As we know, you can get as much as you see in that cavity, but there's also, the portion that's on the other side of the door, the portion that's in the myometrium. And a lot of times, as we know, that's going to herniate over time. You're going to still have problems. So what is your counseling as far as with the hysteroscopic myomectomy? And more importantly, are you comfortable, like, after performing a successful hysteroscopic myomectomy, regardless on what's the other side, now feeling comfortable with implantation, or like how do you counsel patients, or like what's your approach there?
Yeah, so I tend to, like, you're talking like an old grading, like a type 1, let's say, or something like that. I would always try to get the whole fibroid. What I do is lower the pressure down. Usually lowering the pressure will allow the fibroid to kind of just herniate out into the cavity, and I can usually get the whole thing. If I don't get the whole thing, I always try to instead make it flush. I try to get down a little bit further, and then that way I know I'm past that point. And I've actually never had any issues with it healing back over and with implantation. I usually tell people the chances would be about the same when it comes to that. The part I get more concerned about is, like infection afterwards or something like that. That would be the bigger concern. But that's why I like doing hysteroscopies. They're much easier. What you do is much harder. That's where people get storing in the cavity.
Yeah, because I usually, with those patients, I'll do a dual. I'll do a hysteroscopic myomectomy, and then I'll do access or laparoscopic radiofrequency ablation of everything else that's myometrial and serosal. So I'll do a concomitant procedure with both of those typically.
Yeah. I think a common question I keep seeing, and this would be a good one for Dr. Salem and myself, and I think it'd be neat for you to hear our perspective on this, is when do we recommend a fibroidectomy? Like, when do I see a patient I go, this needs to be removed? That I don't even try it until you have this removed. And so, Dr. Salem, what do you like? What do you have to see for you to tell a patient, like, absolutely, you gotta get this removed? What are those situations?
Yeah, I would love to hear everybody's take on this. I bet we'll say 3 slightly different things. So, definitely fibroids that have to come out in my book. Anything, in the cavity that is involving that, inside of the cavity, inside of the house. Then things that are submucosal, those need to come out. The question is, how do they come out? You go through the vagina, through the uterus to get them out, or do you have to go from up top and send them over to Dr. P for him to do his magic? And then the second group, or the next group, is the ones that are inside the wall of the uterus. Now, from a fertility standpoint, I try to look at if they're distorting that potential space inside the house. That house is, when you're looking at the fibroid, is it really crunching down on top of it and changing the shape of it, even if it's not involving it? I also look at the size of it. Generally ones that are above 5 to 6 centimeters, I start thinking more that, hey, we might need to remove this one here. I also look at hormones, quite honestly. Like, there are some unusual cases, like some fibroids make prolactin, so different fibroids have receptors for estrogen, progesterone, prolactin, depending on their genetics. But very interestingly, some of them can make prolactin, and that's kind of a problem when we're trying to help people get pregnant. So that's a small subgroup, but it's one of those things where we get to geek out on the endocrinology of it. And then, the last piece of it, of course, is, are you having symptoms? So if a patient's like, I've got these horrible symptoms, I got pain all the time, I've got, all these things, it's not going to get better with pregnancy, and the fibroid itself is going to get bigger. So I usually recommend taking those ones out as well. The ones I leave alone are what's called, the pedunculated fibroids, or those ones that are just hanging out like a little cap on top of the uterus, and those ones, usually we just kind of tend to leave them alone, at least in my world. But Dr. P, I'd love to hear your take on it. Like, before thinking of doing an embryo transfer, before somebody's about to get pregnant, those ones that are borderline, what are you thinking about with those?
Yeah. So, again, I'll take, each case individually and kind of see what the goals are and see where they're at from a fertility planning standpoint, and see, like, is this something in which you're trying to get pregnant within the next 6 months to a year, or you're trying to do 4 or 5 years to get pregnant. So that comes into play. But I tell them my definition of advanced fibroid disease is when the fibroid is, your dominant fibroid is at least 10 centimeters, and or if the combination of your fibroids bring your uterus to your umbilicus or your belly button and beyond. And for those women, the knee jerk, no matter where the fibroids are at, I think should be addressed. And that's not just for pregnancy, but we're talking about future issues and having bigger surgeries in the future that they need to have, as it pertains to the ones that necessarily have to be addressed or removed or treated. If they are small and in the cavity, there are things that can be done. If you have like a 2, 3, 4 centimeter fibroid and you don't have advanced fibroid disease, things like, the hysteroscopic myomectomy with Excessa is something that I do and something that I would offer them. But that's also depending on age. Someone that's 33 is different from a woman that's 43. And their fertility planning. Someone that's older and trying to do this and really don't have a lot of ovarian life still left, and don't have a lot of opportunities for pregnancy, being a little bit more aggressive with surgeries is a better option as someone that is younger. But any fibroids that are really close or impinging on the cavity, or pushing in significantly where you see it on ultrasound or where you see it hysteroscopically, fibroids that are definitely in the cavity, and they're causing significant distortion of the cavity, definitely need to be addressed in some way, shape, or form if the symptoms are there, and if the desire for fertility within the immediate or near future is there. But like I say, it's a case by case, and some women I've had, like, have had fibroids so bad and they actually have no symptoms, and it's crazy to see that. And then it's women that don't have horrible fibroids, that may just have one submucosal, that have horrific bleeding, have horrible issues. So it's it's very difficult to knee jerk and say, hey, you have to have it. But it's more of a case by case basis. But some of those general things is how I approach it, and at least kind of lay the framework of like who kind of needs surgery versus who doesn't.
Yeah, I mean, I agree with you guys. I mean, obviously, in the cavity has to. At that point, you have to remove it. There's no situation where you wouldn't. Like you, I kind of look at the situation, Dr. B. I look at holistically, and I go, okay, what's our situation, right? Someone who has, let's say, a bunch of embryos, and they only want one kid, and let's say there's a fibroid just pushing up the cavity. Maybe it's really small, just barely pushing in. I will let them. I'll tell them, listen, I don't want to make you go through a surgery. You have, 8 embryos. You just want one kid. It's not unreasonable. Let's just give it a try. Put the embryo back. If we have problems, then we do the surgery, right? Because I mean, for some people, it's a big deal to have surgery. Maybe it's costing, right? I mean, some people don't have insurance and stuff, and now that's a huge expense. And then I think with the other one is like you said, the distorting. I think when things do get distorted, there's a little bit of concern there. My mind's changed a little bit. Like I said, after that surgery where that person had that fibroid, and again, I mean, from everything I've learned, everything I know, it shouldn't technically affect implantation. But what we're realizing is some of these fibroids can be irritating, causing contractions and stuff inside the uterus. It could be causing things. And so, unfortunately, I don't think we'll ever have the answer. So I don't, like you said, there's no one you can tell absolutely which ones you have to remove, except for the ones that are submucosal. But I agree with you guys on most of those. So I don't think we were that far off, Dr. Salem. I think we were all kind of pretty similar on that.
Yeah, absolutely. Yeah, you guys are. I was thinking the same.
The two other things I think would be really cool to talk about is, is like you said, people are walking around with fibroids all the time. I know we're a little bit over time. We'll finish up here soon, but 40% of women who are age 40 have fibroids. It's a very common thing. Many women have them, but the question is, does it matter that they have them? I'm sure a lot of people are hearing this. They heard these crazy stories, but in the end of the day, I mean, people walking around with fibroids, they'll never know they have them, and they'll never have any issues. And I think when they hear the word, like, it's a tumor, how do you explain it to people with this idea? Like when you meet them and they have a fibroid because they heard they have one, now they're scared, but you're like, what's your goals? And they're like, well, I'm fine. What do you tell them? You say, well, don't do surgery. No reason. Like, it's not bugging you. It's not bugging anyone else. So.
Yeah, I always refer back to the goal. And I talk to them and say, hey, if the only reason that you're talking to me right now is because somebody did an ultrasound and told you that you have fibroids, forget that ultrasound and forget what they told you. Because it's you have 70-year-old women walking around with fibroids that are living their life with their uterus and their fibroids, and they're not bothering anybody. So the fact that the fibroids are just there and they're bothering you just because they're there, forget that they're there. When they become a problem for you, you will know that they're there, and now we need to talk. We have bleeding, we have frequency of urination, we have pain with sex, we have pain with our menstrual cycles, we have infertility issues. When we know when they're causing a problem, now we need to have a discussion, because at the end of the day, every surgery has risk involved, right? There's a risk to every single one of them. And if we're talking about removing fibroids, this is a risky surgery. And so when you have a benefit to that surgery, then it makes sense because the benefits outweigh the risk. And if we're doing that surgery to get you to a goal, then now it makes sense to do it because we'll take those risks on for the greater benefit. But when the benefit's not there, now it's just all risk. And if something does happen, you ask the question, why did we do that? Because there was no benefit to it. And you get really, really into a danger zone when you start to take a lot of cases that have all the risk associated with no benefits. And so that's why when I talk to them about it, and it usually light bulbs pop up when I bring it to them that way. Sometimes they're still kind of stuck at that point. And then, I just ask them, then I go just straight back to the goals. What is our goal? And if your goal is, oh, well, I just want to stop bleeding. And that's where it comes in at. And I just tell them there's so many things that can contribute to your bleeding, or they can cause you to have abnormal bleeding that have absolutely nothing to do with fibroids. So if your goal is just to make your periods better because you believe it's your fibroids, what happens if I go in there and I remove all those fibroids and that you still have heavy periods? Are you happy then? Would that make you happy? Well, no. Well, then let's think about it. Let's talk about it, because I can't assure you, I can't give you any assurity that me removing these fibroids is going to make your bleeding better. Because just as much as your bleeding may be contributory to fibroids, it also may be due to anovulatory bleeding, which is your ovaries are starting to decline. You're not ovulating on a regular basis, and now that's the reason physiologic and it has nothing to do with your fibroids at that point. So just having these real conversations, because a lot of times when our patients talk to us, they're talking to us from a place where they have just heard different things. They've listened to different people's stories. They've heard a lot, and they don't really have anyone that has brought it all in and talked to them about true facts, and now truly be able to make decisions off of factual information from experience. And then, that's our job to do. And then they can really appreciate that and make informed decisions from that. And usually, I always have a few patients like, oh, I'm just talking to a wall. It's nothing. I'm going to change your mind. But those patients are very few and far between. Usually, even with patients that come in and say, hey, I came to you for fibroid surgery, that's all I want to hear about. Even those stubborn patients typically will definitely listen to logic and will hear me out, and will listen and make better decisions about that, and even change their mind about what they came into it with.
For the people who are interested in seeing you, I know we've had a couple of people asking, like, how did they get a hold of you? For someone who might listen to this or watch this on another time on a rerun, how do they get a hold of you? I mean, again, because all surgeons aren't the same, and
Sure.
like I said, I actually just one of the patients we saw recently had a surgery done, and after getting it done, there was still another fibroid there, and they had to have another surgery. And so, if someone wants to find you, what's the best way for them to get a hold of you?
So the best way, if you're in the Chicagoland area, or you desire to fly to Chicago to see me, you can reach out to me through email, social media, Dr. P23, and my email address. Everything is Fibroid Slayer, so it's Dr. P DRP at fibroidslayer.com. But for all of the women that are not in my area or just don't have the time to actually come to see me in person, virtual consultations I offer, and that's a majority of my practice are women that actually do not live in Chicago and that are in other cities or even outside of the country. And you can do that at www.fibroidslayer.com, and you can set up a consultation, and I will read everything that you have as far as your records are concerned. Look at your reports from your MRIs and ultrasounds, have a thorough conversation with your history, and look at your goals, and then talk about each option that you have in detail, and answer all questions at that point. So I'm very accessible. I tell people all the time that this is the new age of medicine. The old guard of medicine, to me, is that your options are only as good as the doctors that are in your area, right? If you're in Middle Tennessee, whoever's in Middle Tennessee is that's what you got. And if you don't have any skilled person there, you just go with the best one you have. And I think that's the old guard, and that's the way that it should never be done again. Don't let your
It looks like we might have lost him for a second. But he's correct. You don't have to just see the surgeons where you live. And so again, if you do have a complicated case, definitely reach out to him. Same thing with us. We have people come all over the country to come to us for fertility, and you don't have to just have the person in your backyard anymore. That is the old medicine. I agree 100% with that. And one of the things I wanted to ask him, unfortunately, he's not here right now, and we are near the end anyways, was, what educational sources it has. Like, this is an educational source for fertility. And by the way, the questions we didn't get to, if you do have questions about fertility, we do like a podcast, talk about Fertility Tuesday, and we do the Sperm Meets Egg. Here we go. Dr. P's back
Oh,
again.
sorry about that. So just to finish my thought, do not let your where you live, your demographics dictate your care. You know, like I said, most of my patients are flying in for surgery or getting consultations. And even if you can't fly in for surgery or what have you, always get a second, third, fourth, fifth opinion until you start to hear things that make sense to you. I never say I'm the end all of any person's journey. You know, I encourage every woman to just use me as you can use me as a marker and say, hey, he said this. Let me see who's in my area. Let me see what they're talking about. You know, you should, when it comes to surgery, you have to be very, very careful about who you give the privilege of operating on you, because literally this person that you're entrusting with your life, because you have absolutely, you're defenseless, you have nothing. Once you go to sleep, they are in total control over what's going on, and you have to be 1000% comfortable and trusting in this person. So it may take 2, 3, 4, 5, 6 consultations before you feel good about the person that you're talking to or that you trust with that. So that's definitely how to find me. But like I said, I like people just to use me as a barometer, if you will. If I'm not the person for you for whatever reason, use what I tell you to, you know, to your next consultation and multiple consultations, and wherever you're at, don't just say, hey, this is all I have, these 3 doctors. I have one woman, like I said, and I'll be real quick, the largest fibroid to preserve a uterus that I've done, and it's on my page, is 20 pounds. And, you know, this woman, her fibroid was laying on her IVC, and it was causing pleural effusions to where she had to have drainage 7 times in a year, where we're taking out 2 liters of fluid, and it's pretty much filling up her right side of her right lung. You know, that's what she had. She went to Johns Hopkins, she went to Duke, she went all up and down the East Coast looking for doctors that would not touch her, that would not even attempt to try to preserve her uterus, would not even attempt to try to do any type of low transverse incision, but everything was vertical, everything was hysterectomy that they told her. And so she found me. And I was able to not only do her surgery successfully, save her uterus. She's having normal periods now. She's has AMH over 2 and is seriously now wanting to have a child when nobody gave her that opportunity. But if she would have just took that and said, hey, I'm on the East Coast and it's all I have, and I can't move, she would have gotten a vertical incision hysterectomy for sure. But she took it on herself to say, hey, not only am I going to get this consultation, I'm going to do what it takes to go to Chicago and have this surgery and make my dreams and be in control of my own destiny and my own dreams. And that's what I implore everyone to do, is that take it in your own hands. There is a way to do it. Do it all the time, and you can absolutely travel for surgeries or what have you. Women travel for cosmetic surgeries. You most certainly can travel for surgeries that really, really matter for your life and your future. That's what I got.
I know you didn't brag about this, but I know that you do some outreach stuff too. I was checking out some of the stuff you do for the community, which is pretty amazing. So
thank you.
The stuff you do there. So I just wanted to share one thing, and that is I really love the name, and I'm not saying I'm copying it, but you know, I'm thinking I'm going with the Egg Slayer. And so that's going to be my new one. And so the Egg Slayer is it's going to take over in fertility. So
that is awesome. That is absolutely awesome. I love it.
Hey, thanks so much for coming on. This was really so much fun. And like I said, I really hope a lot of people really realize that there's differences between surgeons. There really is. And I think one guy said best one time, he goes, no surgeon thinks they're bad at surgery. And what I mean by that is that, you know, every surgeon is going to think they're good, but there really are differences. And this is where I would say, if you're ever going to get a fibroid removed, definitely talk to a fertility doctor before you have it done, that they recommend the surgeon if they don't have the ability to see you, and they can at least get them to a surgeon they feel comfortable with getting to the right spot. So,
yeah,
1000%. And to that point, also, I don't think that all fertility doctors are built the same either. Because I've had doctors, I've had patients that come and say, what did they say? I know I'm not a fertility expert, but that just doesn't make sense. Like they shouldn't tell you that either. And, vice versa, good docs, good surgeons have relationships with fertility specialists that they trust as well too. So same way, if it should be a team approach. And if you go to your gynecologist and say, hey, this is what I want, I definitely want to have children, that doctor should be saying, hey, I need to send you to this fertility specialist because they're going to work with me and have a team approach of how to get you to your goal. And they're not going to discourage you. And they're going to be very honest with you, too. So I think that's important. It goes the other way as well.
Well, thanks again. And anything else, Dr. Salem, you have to add?
No, I really want to thank you. I really appreciate your perspective. It's so enlightening for everybody in the community, the fibroid community, the fertility community. And thanks for all the teaching today. Thanks for all the hard work that you do. So it's great, and hope to be, again, we'll definitely hope to see you in the near future.
Yeah, you guys owe me one. So because I have the Fibroid Slayer community as well too. So I started about 4 months ago, and I got about 600 women that are in the community. So it's my own platform where they're talking about everything. I do my lives there, and they have their endometriosis group, pelvic pain group, fibroid. They have their own groups, and they talk, and it's very interactive. It's awesome. But I want to get you guys on there to have this conversation.
Absolutely.
I'm asking you a lot about fertility stuff too, because it's very important. When I talk to these women, every single day I talk to women that are clueless about how to get, about fertility and how to really achieve that goal. And it's like, I'm the first time that they're hearing somebody say, hey, let's not focus on fibroids, let's focus on eggs. And that's the first time they're hearing it, and they really need to hear it from experts and have, some very real conversations and some information. I think it'd be awesome and helpful.
We'll definitely do it. Would love to. If I ever come to Chicago too, love to meet up, maybe get some heralds or something like that.
Absolutely, man. I got to take you out, have a good time. Come when it's a little warmer, and we'll have a great time here, man, for sure.
Yeah, we were in Minnesota, so we're not afraid of the cold. So
awesome.
Have a good one.
For sure.
All right.
Thank you guys for having me. I appreciate it.